This is the Chuck Says Words podcast with your host, Chuck Jackson, a show dedicated to navigating the complex world of building a service-based business, finding and leading successful teams, and not getting in your own way. Whether you are bootstrapping or have a plethora of investment cash, business is hard. So if you're ready to explore ways to make it easier, hear some wild stories, and walk away with some great anecdotes, then join us. This is where Chuck Says Words. Now, your host, Chuck Jackson.
Welcome to the Chuck Says Words podcast. I am your host, Chuck Jackson. I am the founder and CEO of a boutique consultancy, 9 Mitchell Consulting. You can find us on the web at 9mitchell.com. That's the number 9. mitchell.com, or search 9 Mitchell on LinkedIn. You'll be able to find us there as well. So my consulting firm is a small team. We consider it a boutique consultancy that operates in the healthcare and other human services space, where we really strive to help those small healthcare providers, human service providers, behavioral health, substance use disorder treatment, get a handle on their administrative, their compliance sides, make sure that their HR is operating well, make sure that they're not running into issues with licensing, that they're able to get accredited, that they have solid policies and procedures and processes in place, and that they're hiring the right people and giving them the right tools to thrive in our exceedingly complex healthcare environment, right? Dare I say that every single day in the U.S., the ability for small providers, or any providers really for that matter, to do any kind of real services becomes more difficult every day, right? Rates are getting cut, getting approval and pre-authorizations is becoming harder and harder, and it's just the world we live in, right? So that's why we exist, to help those types of providers out there. So this being the first episode of the Chuck Says Words podcast, where I really just share my musings on all things healthcare and human services and small business in the world, right? Because there's a lot of challenges out there, and my hope is that whoever ends up being part of our listenership gets to hear some things that really can help you become better at what you do, right? And so the first episode, being a solo episode, I'm not going to be interviewing anyone or bringing any of my team on for their thoughts on anything yet. Just want to kind of give this a shot and see who out there in the world might be listening, right? So one of the things I plan on doing in every episode, and this is one of the promises I'll make until the end of time, is I plan on highlighting something that is happening out there in the world, whether it be a provider that's doing great work, or maybe it's a provider that's not doing such great work, or maybe we'll talk about some fraud cases here and there, right? But I like to call them case studies. There's scenarios and situations out there in the world where people ran up against certain circumstances and really were up against it in some way, shape, or form, or they did something that's exemplary that I think the folks out there that might listen to me might benefit from. And so, I will do a case study every single episode. The goal is to bring on professionals out there in the world and interview them and really pick their brains and ask them, really good questions, difficult questions about how they were able to succeed doing the things that they were doing. I also plan on bringing on my team so we can hear firsthand the struggles that some of our clients have faced and the way we've been able to navigate the tumultuous waters of healthcare, right? So that's the goal. And that's our first episode introduction. I won't go into grand detail in future episodes, but, if you're joining us in episode 40, 140, 400, or 4,000, assuming that we get to that place, I want you to be able to come back here, episode 1, not a long episode, and actually hear who we are and where we started and what we're doing, right? And hopefully we're just able to put out some good information, some good content out there for people to be able to listen to, enjoy, and use. That's our hope, right? So with no more ado, let's get into this very first episode. And the case study I want to bring right now is really one that I've used countless times. There's no way I can put a number on this, but it was brought to my attention in, if I go back, sometime in early 2019. And it's really a case study in thinking outside the box, pulling information and successes from other industries and applying them into the healthcare field and healthcare industry as a provider to really give a first-class, top-notch experience to your patients, right? And I think we all in the healthcare industry understand that it's really important to give a really good experience to our patients. Because I will tell you, I spent a lot of my career on the regulatory side at the Arizona Department of Health Services and Licensing, and I've seen the bad that can come from providers that don't care about the quality of the service they give, that they're just there to see people and write and cash check. I think we all know, if you're in this industry, if you've been interested in listening to this podcast at all, then chances are you're not the type of person that just wants to cash the checks, drive the Maserati, and just give a subpar product or service, right? The case study I'm going to bring up is Virginia Mason. It's a health system in the Washington State and Seattle areas. And, bear with me, I'll pull it up on the web here in a second, just so in case I need to reference some things. But this is the way the case study was brought to me. At the time, I was working for an FQHC. And if you don't know what that is, if it's not your bread and butter in the healthcare industry, that's a federally qualified health center. They are federally grant funded to help offset the cost of giving services, primary care and some specialty care and some urgent care, to patients in areas where there might not be another mechanism for them to pay for services, whether they don't have insurance or it's an impoverished area. If you've ever heard of a rural health center, they fall into a similar category as an FQHC, a federally qualified health center. If you're familiar with that level of care, with an FQHC, you know that their pockets are not deep. It doesn't matter how many people they see. The economies of scale are very, very difficult to work through and to become a very profitable business. First off, they're all nonprofits. They all have to have a governing board that is 51% or more comprised of patients. So the whole idea behind an FQHC is to give a top-notch, first-class experience to folks that might not otherwise have those opportunities. And Virginia Mason was brought up as an organization who had done some good in a different way than we're used to seeing. Let me set the stage for you, right? You go to a doctor's office, you check in at the front desk, you go and sit down, maybe you fill out some paperwork, maybe you don't, and you're sitting there for a little bit and you get called back at some point. All too often, I know I've experienced this more times than not in my lifetime, you have an appointment for, say, 3 o'clock in the afternoon. You show up 2:50, 2:55, you check in, you sit down, 3:30 rolls around, and you haven't been taken back yet, and you're frustrated. The visit is already not starting off great. You might hear some apologies and whatnot, but the place is overbooked. The physicians and the nurses are spending too much time with the people before you, that you're being delayed in receiving your care, and that puts you in a little bit of a way. What Virginia Mason did was they sent some of their operational folks to Japan, and they met with, this is my understanding of the way the story goes, and they met with some Six Sigma pros, some of the folks that actually developed Six Sigma for Toyota in the 80s, right? And, let me apologize if I get some of these facts wrong. Maybe I don't have the dates right and whatnot, but I'm running off memory here. And one of the questions that gets asked of the Virginia Mason folks is this: why do you even have a waiting room? What's the point behind the waiting room? And they'd never thought about it. Why do we have a waiting room? Well, everyone has a waiting room. You check them in at reception, you put them in a chair, and they rest their bum there until it's time to actually go back and start seeing professionals. Well, this got everyone thinking, Virginia Mason, at Virginia Mason. And what they ended up doing was realizing that wasn't necessarily a necessary construct that they had to follow. So they developed a way at some of their clinics for when a patient comes in for a scheduled appointment, they are able to take them they check in at registration, somebody comes out before they ever walk away from registration, takes them into a room, and that's the room where they're going to receive their treatment. They're going to see their nurse, They're going to see any care coordinators that they see. They're going to see their doc or their mid-level practitioner like a PA or an NP. They're going to receive all their care in that room, and then when they're done, they're going to check out from that room and leave. This offered them a few opportunities. One, they don't have to worry about upsetting somebody now as easily as they would if they were sitting in the reception area 15, 20 minutes past their appointment time. Now, their appointment gets started immediately. Maybe they still have to wait for their physician or their mid-level to come in and see them after they see nursing or an MA or whoever, care coordinator. But they're better able to schedule through the visits when people get into the queue, into the room, and are able to be seen a little faster. Also, there was some savings in staff, right? Now they don't need as many non-medical staff. They don't need a scheduler to sit at a desk and schedule follow-up appointments or anything like that. Now they just rolled that into the care coordination model, and that care coordinator can handle that in the room at the time before they walk out. This also has patients spending less time in the waiting room at reception, talking to more and more people. It really is a very interesting model to me, somebody who's never experienced anything like that, except one time, which I'll share that experience in a moment. For the most part, we in America do our healthcare by checking in and waiting, and many times, and I don't have data on this, I never bothered to pull it up, but I've never worked with a facility that did not frequently have appointments starting late because previous appointments would run long, things of that nature. So let me talk a little bit about that one experience I had. During COVID, when waiting rooms had to deal with social distancing and you have masking and whatnot, I did make 2 trips to urgent cares, 2 separate urgent cares. They were competing urgent cares within a quarter mile of each other. They were practically across the street from each other, and this was in the Rochester, New York area. And the first urgent care during COVID would check you in on the phone and have you wait in your car until it was time to come in. That was all well and good. The second urgent care, however, would have you come in, check your temp and screen you and make sure everything was okay, and then bring you right into an exam room. And they did that so they didn't have people milling about the reception area. Now it's an urgent care. And what would they do if there was an overflow? Well, unfortunately, they would still send them to their car and wait there to be called in. But the fact that they put people directly into a room and started the care process sooner, one of the things I experienced with that is we were in and out much faster than the first urgent care that sent us to our car for a little bit. In both instances, they were for screening for COVID, getting COVID tests, and also seeing the doc to potentially get antibiotics or antivirals or flu if it was not COVID, right? And the second experience where we got put into a room immediately, there were more people there, but being seen faster, and our visit was roughly 20 minutes shorter. It was about 40 minutes to 20 minutes in the 2 visit sides, so half the time. And of course, when this happens to me, I think, where have I seen this elsewhere? I work in this industry, and the Virginia Mason scenario, where they eliminated waiting rooms, totally sits in the top of my mind when I think of why one urgent care would do that versus another. Do I know if that urgent care had any idea that Virginia Mason had already eliminated waiting rooms? No, I have no idea. But I will say it's a very interesting dynamic, and we've shared that potential dynamic with quite a few of our clients who deal in primary care and specialty care with their patients, right? Now, we've also been looking at ways to replicate this into the behavioral health world. Now, in the behavioral health world, there's multiple different levels of care that could be coming in for individual sessions, therapy sessions, coming in for 3 hours of treatment a day, 1, 2, 3 groups, coming in for 5 to 6 hours of treatment a day at the partial hospitalization level. And no matter how you look at it, there are ways to do this. And we know of 2 facilities right now that we've worked closely with that have effectively eliminated any type of wait. Part of that is because they work really closely with the housing providers, if there is one, that will transport their patients to them so that they can receive their treatment and whatnot, if it's a partial hospitalization or an intensive outpatient level of care. Some of them have their own housing associated with the program and whatnot. But a couple of them, the ones that were able to eliminate waiting rooms effectively, are of the type that don't have a captive audience at their own housing. What they have are people that are working during the day and coming in for evening groups, or they work in the evenings and they come in for morning groups. The people come in when it's their group, they get assigned their room and they get walked back into the group room that they're going to be in. There's no need for any type of reception. Behavioral health is different though than primary and specialty care. It's very rare when a standard looking outpatient behavioral health clinic will have somebody come in and say, "Hey there, Mr. or Ms. Receptionist, I need to see someone now for some mental health or substance use issues that I have going on." You don't really see that. Instead, it's all scheduled out a week in advance, 2 weeks in advance, a month in advance, and people know when they need to be there. But at any given time, you might be running 3 groups with 15 people each, 10 to 15 people each. That's 30 to 45 folks all in the clinic, all arriving around the same time, and they check in and they get in their room and they sit. It's not quite the same as primary care, but it's not entirely different. And so I think the takeaway here is this. Just because you're used to something, like using waiting rooms and large reception areas, and that might be all you've ever seen, it doesn't make it the only way to do it, right? There's more than one way to skin a cat. And I won't recommend skinning cats. We got 4 of them. There's 2 of them running around here in my home office right now, actually. But the euphemism works in this instance, and that is there is more than one way to skin a cat. So when in doubt, think it out, right? And I don't mean to sound goofy or tacky or anything when I say that, but there are a lot of ways to accomplish giving great care to your patients and your clients. So just think of the experience that you're giving to folks. And if the experience can be improved upon, consider those options. And so, I recommend hop online, look it up. It's Virginia Mason. They actually have a consulting arm. It's called the Virginia Mason Institute. They do a lot of data and whatnot. An article on advisory.com, Why One Health System Eliminated Waiting Rooms. It's from 2012. So it's a while ago that this came up. I see some stuff here on modernhealthcare.com where they were talking about it as early as 2009. There's a PBS article from October of 2012 where they're talking about their redesigned medical clinics and eliminating waiting rooms. And it's just wild. So hop on the web, open it up, take a look at a few of the things that they've done. I've heard through the grapevine. I've never been to a Virginia Mason clinic because we operate mostly in the Southwest with a few clients on the East Coast and up and down the Midwest. So we don't currently have clients up in the Washington State area. And, Virginia Mason has the deep enough pockets that they're not going to call Tiny Nine Mitchell Consulting to come in and help them out because, like I said, they're a case study, right? And there's a reason for that. But I heard through the grapevine that they brought back some waiting rooms in some of their places, and there's a reason for that, right? I don't necessarily know intimately what that reason is, but I'm confident that a company like that, Virginia Mason, that got a lot of focus a few years back about doing something novel, that they really did think through what they were doing. So that's the case study for episode 1, right? Engage with us. I will engage with us via LinkedIn. My team's planning to put these podcasts up on YouTube as well. So you can watch them in video. That's why I'm sitting here staring at a camera, which I'm totally uncomfortable doing, but I'm actually really enjoying this. And, we'll be posting this on all the major podcast sites like Google Podcasts, Apple Podcasts, Spotify, and whatnot. But engage with us, right? Find us on LinkedIn. Send us a message on LinkedIn. Find us on YouTube and comment on the podcast video or any of our other videos. We love to have these discussions, me and my whole team. We're not just doing this so that we can find clients yet. Maybe a few people will want to work with us when they get to listen to some of what we have to talk about, but that's not why we're doing it. We're doing it because there's a lot of people out there that don't hear these stories, and that's what matters to us. So just keep that in mind, right? You can always find us. You can always engage with us. We'll share resources with you. We'll point you in the right direction. But, I just did a little Google search. Type in Virginia Mason, no waiting rooms. See what you got. If you're in this industry and you're interested in good patient care, I am confident when you read these stories, it'll get the gears turning, and you'll want to consider some of these things at your own clinic, right? So let's transition a little bit into something else that I want to take a little time to talk about. And, I'm just taking a look over here. We're about at the 20-minute mark, so I'm not going to keep you for much longer. But there's something going on out there that I think folks need to be a little bit more mindful of, right? And that is screening for, doing a suicide risk assessment. And this is specific to the behavioral health realm mostly. I mean, there are some crossover and whatnot, but on the regulatory side, I think how I would label this is your tip of the episode, right? So out in the accrediting world, the Joint Commission expects to see a nutrition screen, a pain screen, and a screening for potential self-harm or suicide risk for every admission in a behavioral health facility. And they actually expect to see it in some other facilities as well, but I'm focusing on behavioral health right now because one of the things that we see, those are some of the screens that are most likely to have been missed or skipped at the time of admission, right? Suicide risk, not as much as the other two. And the other two, it's been an expectation of the Joint Commission now for quite a few years, but it's still one of their top 10 most cited standards every single year. And so I just want to talk a little bit about that. One of the first questions that we get from almost everyone we work with is, can it be embedded in another assessment? Yes, it can. It doesn't matter who asks it, as long as they're skilled in asking it, or when they ask it, so long as it's done at the time of admission, around the first contact you have with them, because it helps you determine whether or not you're the right place for them now or in the future, and whether or not you need to refer out for any kind of additional care. Suicide risk assessment can also deter. The Columbia scale is the one that is most commonly used that we see out there. And you do that screening. It does not take long, a few minutes. You ask a few questions, you get a few answers, and then you give it a numerical score. And that numerical score will tell the clinical team whether or not they have to put some added safeguards in to make sure that that person is safe until the time they start treatment. And then you want to reassess them later on to make sure that your treatment is working to help them and make them a little more safe, right? For nutrition, and we see this in the substance use realm a lot, is that the nutrition screen will show whether or not somebody potentially has an eating disorder or whether or not they do need some education on how to handle their own nutrition effectively. And it also identifies any dietary restrictions or allergies or anything like that. So there's a few reasons for the nutrition screen. And then the pain assessment, especially in our substance use facilities out there. If you think of the reason why somebody might be addicted to any type of opioid, a lot of times it started with some type of pain situation. So it's really good to know whether or not somebody is experiencing any kind of pain at the time they come in, because it's going to alert you to whether or not you need to give a particular kind of treatment, refer out, see a pain doc. It'll also help determine the type of tapers that might be prescribed by your medical practitioner with that particular individual. Now, there's a lot of other reasons, but these are the main reasons. So the tip of this episode is, if you're in the behavioral health world, be mindful that you need to screen for those three things, because it's expected with your accreditation if you're accredited by the Joint Commission, but it's also at this point considered a best practice of care. So that's your tip. So, our first episode, that's our case study. Virginia Mason, look them up. They are They are an outstanding provider up there in the Pacific Northwest in the Washington State area, surrounding Seattle as well. Kudos go out to them. And, tip of the day, pain screen, nutrition screen, suicide risk screening. Make sure you do those because it's important. All right. So with no more ado, I'm going to sign off on the first episode of the Chuck Says Words podcast. I appreciate you taking the time to listen. And again, reach out and engage with us. You can talk to myself or any member of my team. Find us at 9mitchell.com or on LinkedIn. Search 9Mitchell and you'll find 9Mitchell Consulting there. And we'll gladly listen to what you have to say and give you some hopefully actionable steps that are able to help you out.
All topics discussed on this podcast were for information purposes only. Please seek a licensed legal or medical professional whenever necessary. If you need help with the strategy or direction of your service-based business, you can find our team at 9mitchell.com.